So I would like to speak today about a new condition described and named as PVAC for peripheral exudative vascular anomalous complex. It was initially described in 2011, and maybe because it was published in a French journal, well, it was not very known, even among retina specialists. It was described by Giuseppe Querques. It's available online on the French Journal of Ophthalmology, and it's written in English if you want to refer to this paper. And recently, a large team from Créteil, from Milano, from New York and Los Angeles expanded the spectrum of the condition, and they reported 15 eyes with this condition in the American Journal of Ophthalmology. So the purpose of today is to say, well, does PVAC really exist? Because finally we have 15 cases in the literature at the present time. And we also wanted to analyze the multimodal imaging findings in this condition, and finally what we know about this condition. So we present a retrospective case series of 8 patients, 8 eyes, because it's a unilateral condition, diagnosed with PVAC according to the criteria of Giuseppe Querques. It was performed in Paris, and of course we performed fundus photography, fluorescent angiography, and OCT spectral domain. So what is PVAC? It could present as some hard exudates with a small red lesion in the center. There is nothing in periphery, the second eye is normal. And if you perform fluorescent angiography, you will see a kind of microaneurysm with some leakage at the late stages of the fluorescent angiography. In B-scan, the typical findings are a round hyperreflective lesion with a reflective wall and frequently a less reflective lumen of the lesion. There are also hard exudates, as I show you on the fundus picture, and there are intraretinal cysts associated with the condition. So we had 8 patients like that. We have 4 male and 4 female, and as you can see, they are middle age or a little bit more aged. And frequently, the initial diagnosis was MACTEL in one case, pseudophakic CME, type 3 neovascularization, or exudative AMD without any precision. And we found that visual acuity usually was not too bad at least, and sometimes very good. And patients may have coincidental eye disease. We don't know finally if it's coincidental or not, a kind of pattern dystrophy, 2 patients with myopia and a thin epiretinal membrane, and some patients presented with vitreometral macular adhesion, but no traction, or a thin epiretinal membrane. This is what I told you. Let's see one case, for example, of this red lesion in the fundus, and there was a vitreoretinal adhesion, but without real traction that could explain the presence of foveal cysts. We perform, of course, OCT angiography in this condition, and the location of the lesion was very variable. In 2 cases, it was mostly in the superficial capillary plexus, and let's show the pictures. Maybe it will be more easily to see. So we had 2 cases in which the lesion could be seen in the superficial plexus, but we could also distinguish it in the deep capillary plexus. On the contrary, 2 patients presented lesion only in the deep capillary plexus and not at all in the superficial capillary plexus. And most frequently, in 3 cases, the lesion could be observed in both plexi, as if it was located behind the 2 plexi. We had 1 patient, the lesion was unique in 7 eyes, but 1 patient presented 2 lesions. It was an aged woman with minor myopic changes in the fundus, and she presented with 2 PVAC lesions. The presence of two lesions also was described in the series by Kerkes and co-workers. We had associated findings such intraretinal hemorrhages, lipid exudates, and intraretinal cysts in all cases. We observed a capillary rarefaction around the lesion in 6 cases out of 8. It's not a huge capillary rarefaction, but it's present. Well, it's still present in the peripheral area. Concerning the follow-up, finally we have 3 patients with a large follow-up, and 2 of them are interesting, I think. This patient is a 45-year-old female. She complained from metamorphopsia, and her ophthalmologist decided to treat with 3 intravitreal injections of ranibizumab because he considered it as a type 3 neovascularization. So he decided to treat with 3 intravitreal injections, but there was no change, and she was referred to us at that time, and we observed this PVAC lesion. So I decided to treat the patients with laser because she did not want any injection more, and finally it works initially, but we had a recurrence 7 months later, and I treat her again on this lesion with laser directed towards the lesions, and finally it works. And we have a follow-up of 18 months without recurrence for this lesion. Not so difficult to treat. Finally, it's like a microaneurysm. We also have a man, 60-year-old man, with moderate visual loss when we see him initially, and there was no real leakage, and we decided not to treat, of course, this patient at that time. We did not know what was the diagnosis. But he came back 3 years later with a moderate visual loss and some exudation on the OCT. So we discussed laser, anti-VEGF, and he finally decided to be treated with anti-VEGF, performed initially 2 intravitreal injections of ranibizumab, did not work, so we switched to aflibercept. The patient said, I don't feel that it's good, and aflibercept doesn't work on me, but finally there was no real change. We switched back to ranibizumab, and finally the exudation disappeared fully. The lesion is still present in OCT angiography, but there is no more exudation, and we have now a large follow-up for these patients. So this is the second series of PVAC, and I really think that it does exist. Some patients may present with this kind of unique lesion. It occurs in one eye of patients with no systemic or ocular condition associated with aneurysms. It differs from retinal vein occlusion, diabetic retinopathy, RAP. There was no sign of AMD in our patients, no vascular inflammatory disease. Could it be a minor form of MACTEL1? Well, it could. However, it seems unlikely because typically MACTEL affect young patients, more frequently males, and we had patients of both sex and a little bit more aged with a mean age of 68-year-old. So probably, I don't think that it could be a MACTEL, but finally we don't know. In our cases, OCT-A was unable to identify the vascular abnormality, to locate it precisely, predominantly in the superficial capillary plexus or strictly in the deep capillary plexus or between mouths. It allowed us to confirm the isolated nature of the lesion. There was no sign of capillary remodeling except soft rarefaction, but as I showed you, this is not a huge rarefaction. So laser photocorrugation was successful in one case, multiple anti-VEGF were efficient in one patient, and it differs from the published series in which 3 cases were treated without any response, but they treated only with 3 injections, and maybe it was not enough for this kind of lesion. So further studies, of course, are needed to evaluate the efficacy of anti-VEGF therapy. So, in conclusion, multimodal imaging, including OCT-A, showed that PVAC is an isolated large aneurysm abnormality with flow localized in the SCP or the DCP or in both, plexi. PVAC must be differentiated from other vascular abnormalities. Its treatment is not known, but we could say that laser photocoagulation and/or TVGF therapy could be proposed in affected patients. I thank you for your attention.
Thank you very much, Salomon. And he has to leave after his talk, so if you have questions, please ask him now.
Yes, I'm sorry about that, but if you have questions, it will be now.
Yes, Maji?
Actually, it's a very good presentation, and it's actually for me, I have cases there. I have similar cases, but I've never thought of this diagnosis because it's the first time for me to find out this. As you said, it's published in French a couple of years ago.
No, it was written in English, but it's a French journal of ophthalmology. But the last publication was published in the American Journal by Giuseppe Querques. You will find him.
I found the title, but I didn't read it, but I thought, what is this?
You should read it. It really does exist, I think.
This is a very good presentation, but let me ask you, you said it could be a MACTEL or it could not be, but I agree.
To my opinion, it's not.
It is not.
To my opinion, it's not. It would be a too large spectrum. And usually in MACTEL, you also have a huge rarefaction of capillaries. This is not the case. So what is your opinion, Wick? Do you have an idea about, is it?
So MACTEL1 characteristically is in the temporal location. This can be found almost anywhere. It's often found MACTEL1 has loss of the deep capillary plexus in that zone where they have the cystoid edema, and this not so much.
No. So I think it's different. Also.
Yeah, and why this is parafoveal is another aspect that's kind of bizarre, right?
Yes, it's curious.
Yeah.
Please.
Thank you for this very nice presentation. We know that about 5% of non-diabetic patients have microaneurysms when they are 60 or older. So don't you think it's just, microaneurysms due to atherosclerosis, which may leak from time to time and resolve spontaneously?
We don't know, maybe. But in your practice, do you think that really 5% of people aged more than 60 have microaneurysm?
Well, it has been published,
I
from
know.
retinal photographs, so maybe...
I know, but is it really true?
Like everything which is published.
Salomon, can I ask one thing?
Of course.
You showed a case that exudation disappeared after laser photocoagulation, but OCT angiography showed still detected blood flow. So in this disease...
No, it's after anti-VEGF.
After anti-VEGF.
Exudation disappeared, but the lesion is still present.
I see, but not after laser.
Not after laser.
Thank you so much.
Thank you.
Yes, thank you so much. Thank you.